Good afternoon or morning, everyone, depending on where you are joining from. My name is Shannon Allen, and I'm the Marketing Director here at TeleSpecialists. I want to welcome everyone to our Lunch and Learn series of Keys to Diagnosing and Managing Concussions. We will have Dr. Sandro Corti and Dr. Neil Patel joining us today to speak about those items. If we want to, just give you some background. Dr. Patel is a board-certified neurologist who completed his neurology residency at SUNY Downstate in Brooklyn, New York. He completed his sports neurology fellowship at the Pearl and Jobe Institute in LA, and he attended St. George's University for medical school. Dr. Patel joined TeleSpecialists as a teleneurologist in 2020, and he currently resides in Brooklyn, New York. Dr. Corti will also be joining us as a board-certified neurologist who completed his neurology residency at SUNY Downstate, and he is a neurology resident at he completed his neurology residency at SUNY Downstate, and he completed his neurology fellowship at the Kuchner Clinic in Brighton, Michigan. He attended Rutgers, New Jersey Medical School in Newark, New Jersey, and Dr. Corti joined TeleSpecialists as a teleneurologist in 2020 as well. Dr. Corti currently resides in Manhattan, New York. Just to inform you, there are no disclosures that we need to provide to you either moving forward on either of the positions. So with that, I will turn it over to Dr. Corti to start our discussion. Oh. Dr. Corti, I think we're just on mute there for.
Okay, can you hear me now?
Yeah, good.
Okay, all right, so the discussion topics are: what is a concussion? Tips for the neurologic evaluation of concussion patients, management options, including outpatient follow-up recommendations, and when to consult a neurologist. And then at the end, briefly, an overview of sports neurology itself. So first off, I wanted to kind of go over what is a concussion, and that is the best way I can describe it is a traumatic injury to the brain caused by a force transmitted by direct impact or whiplash, which causes a disturbance in normal brain function on a structural level typically too small to detect on standard brain imaging tests. Now, when we say a traumatic injury to the brain, we usually stop there and don't go any further. So today I wanted to go into what exactly is happening on a structural level. And when you understand that, you understand why we're seeing the symptoms and exam findings that we are and why we're looking for them. So first off, this is a very busy slide. I'm going to try and get through this as painlessly as possible, so just stick with me for a minute. So the main thing I want you to get out of this is that mechanical forces distort cellular membranes. So that's where this all starts. You get the hit to the head, and then the membrane of the neuron gets distorted. And then when this happens, even if very briefly, this will cause changes in the balance of ions across the membrane. So potassium escapes the cell, and sodium and calcium enter the cell. And this causes depolarization. So depolarization signals downstream through the axon and ultimately releases glutamate at the end. And now glutamate is an excitatory neurotransmitter leading to further depolarization in adjacent neurons, causing a chain reaction. Now, depolarization is what our brain does normally to transmit electrical signals as part of regular brain function, but this is also normally done in a very coordinated fashion, as opposed to diffusely due to injury in the case of concussion. After this happens, so membrane ion pumps start to work to restore the ion gradient using ATP from glycolysis and the mitochondria. With intact membranes, there's easily enough ATP to correct this imbalance, but when the membrane is disrupted, there's a prolonged need which depletes the ATP supply. While this is happening, excess calcium is also entering the cell and is starting to get taken up by the mitochondria, which causes mitochondrial dysfunction, leading to lower ATP production. So ATP is getting used very quickly to kind of restore this balance so that nerve functions normally, but there's also dysfunction at the mitochondrial level happening over time, leading to less ATP available. If this dysfunction is severe enough, signals are produced to begin apoptosis, which is also known as cell death. Now, if that's not enough, axons are also being damaged, sometimes just by the stretch injury of the trauma, and this leads to influx of calcium there as well, and this can cause impaired transport and delayed connectivity through phosphorylation of neurofilaments and collapse of the microtubules. If that is severe enough, the axons can also die on their own. Now, one other point I'd like to mention here is that for any headache specialists here today, this spreading depolarization may ring a bell. There have been comparisons made between this kind of diffuse depolarization and the phenomenon known as cortical spreading depression that is seen in migraines. So the current hypothesis is that this is why the symptomatology between concussion and migraine is so similar. Now, this is known as the Neurometabolic Cascade, very familiar within the concussion community. This is a somewhat simplified slide of what's going on that metabolic level. And these changes are kind of what we just described with the potassium and calcium changes. And then there's the glutamate of the nerve at the end. And then there's an initial increase of glucose to try and help with a supply for glycolysis. But then ultimately that gets depleted and stays that way for several days. Now, the main thing I want to get out of this slide is the decreased cerebral blood flow. Now, that is something that lasts several days, and the cause of that decreased cerebral blood flow is still unclear at this point. So there are some possible causes, which include disruption of the blood vessel integrity within the brain, or loss of cerebral vascular autoregulation, both of which could be caused directly or indirectly by the trauma itself. But there's a current belief that there is a correlation between the duration of the acute concussion and the duration of the decreased cerebral blood flow, because there have been also separate studies that have shown that when a second concussive event occurs during these 7 to 10 day window, the decreased cerebral blood flow can last several weeks. So that is kind of where we have been currently basing our 1 to 2 week period of rest, of cognitive rest, and staying out of play to kind of allow this to recover, because we also have seen that if you allow this cerebral blood flow to correct and then get a second concussive injury after it's been corrected, there's a similar 7 to 10 day decrease. So it's shown that a second injury after recovery suggests it's its own separate injury, as opposed to an injury while it's recovering, leading to significantly worse outcomes and recovery times. Now, just to summarize, so there's increased energy demand to restore this membrane, and it's being supplied by the mitochondria. And then there's also decreased energy supply. So the cerebral blood flow is not supplying the same amount of oxygen and metabolites needed to help correct this imbalance. So you ultimately have an energy crisis leading to neuronal dysfunction. And it's I want to mention it's neuronal dysfunction, not loss of function, which we'll come back to a little bit later. And so overall, when you think of concussion, I want you to think of these pictures. So basically, it's not that the pathways are no longer functioning. It's that there's a delay in signaling. There's traffic along these neuronal pathways, and the signals aren't getting where they should be in the amount of time that they're supposed to. And so every concussion is also different. So different areas of the brain will be affected differently based on several factors. Where did they get hit? How hard did they get hit? What are their susceptibilities? What's their pre-existing history? And so that's why every concussion patient has kind of a different combination of symptoms and findings, and take different amounts of time to recover.
So I wanted to briefly go over the different concussion symptom subtypes that we have, once we kind of understand what symptoms can come from a concussion, we can better understand what information we should get in the past medical history, the HPI, and the exam, what symptoms we can attribute to the concussion itself versus something else. So this graphic here on the left kind of shows us the 6 broad categories of concussion symptom subtypes. And I'd like to add a 7th one for myself, which is cervical, because we have found that that is also another area that needs to be addressed. So the 7 subtypes that we have here are cognitive, fatigue, vestibular, ocular, headache and migraine, anxiety and mood, and cervical. And you can see with this graphic over here, there's a lot of overlap between each one of these categories. So I'll briefly kind of go into each subtype and some of the symptoms that we can get from each one of them. The first one up is cognitive and fatigue. So some of the symptoms that we can get after having a concussion are decreased concentration, increased distractibility, difficulty with learning, multitasking. Some of these issues could have been present prior to the concussion, and knowing what symptoms they had before can help us figure out what is worse and what is new. Next up, we have vestibular symptoms. So very common symptoms after having a concussion affecting your balance, coordination, and stabilization. BPPV has an increased incidence after having a concussion. So symptoms of vertigo, vertiginous symptoms, spinning sensations of the room or yourself are all very present after having a concussion. And if they're identified early enough, we can have targeted therapy towards those. Next up, we have ocular symptoms. So these can present as trouble with focusing, tracking, processing, reaction time, things as simple as double vision. This can be present just with regular looking around the room or specifically task-specific items like reading or scanning a field if you're an athlete. Next up, the big category is headache and migraine. So it's important here to understand if patients have had a personal history of headaches or migraines. Are these similar to those prior episodes or are they completely different? They'll present very similar to any type of migraine, presenting with light sensitivity, sound sensitivity, nausea, and vomiting. Once we know what their triggers are, we can better have an idea of how we should approach the treatment for concussions. Next up is anxiety and mood. So this can present as increase in nervousness, irritability, depression, troubles with sleep. Addressing all of these specific issues are important because without these, patients will have a difficult time recovering from their symptoms and integrating back into their normal daily activities. Next up is cervical. So I like to add this as a separate subtype because symptoms here can definitely trigger a lot of other symptoms in other categories. So typical whiplash types of injuries, you have muscular injuries in the upper body, shoulders, neck. You can have radicular symptoms presenting from cervical radicular roots, and then you can also get cervicogenic headaches from the occipital nerve or facet-related pain. So here's another area where we want to specifically ask questions and gear our exam towards, because if we have symptoms here, we can address them and reduce some of the other symptoms. So I wanted to go over the timeline of symptoms after having an event. So most concussions get better within 7 to 10 days, as Dr. Corti described earlier. If symptoms last longer than that, after 10 days, we describe them as persistent concussive symptoms. If symptoms last longer than 3 months, that's when we use the term post-concussion syndrome, which is different than chronic traumatic encephalopathy, which is a pathological diagnosis. We hear that a lot in the news. People thinking that they have CTE, but as of now, that is only a diagnosis of pathology at autopsy. And then we have a clinical diagnosis, traumatic encephalopathy, where we have a history of multiple impact exposures, 8 to 10 years of delayed onset, where in the past 2 years you have a history of neurocognitive decline. Next over, we'll talk about the components of the neuro exam.
All right, so when you're considering about doing a neuro exam in concussion, there's the regular neurologic exam, which are the cognitive components, cranial nerves, motor, sensory, coordination, and gait, which you would do on any patient that comes in with a neurologic complaint. I'm not going to focus on those today. I'm going to focus on the specific findings that you see, the high yield findings you see in concussion. Now, those incorporate two particular areas. One is the vestibular-ocular motor screening test, and the other is balance testing. So briefly before I go into that, I want to make a point about history of present illness. So this is still the most crucial aspect of diagnosing concussion. The history will basically be consistent with the concussion based on the timing and the symptoms. So really being a detective on that is going to be the most helpful thing, more so than in any exam finding that you get. Obtaining the patient's account and a witness account, if possible, is extremely useful because if you're only getting the patient's account, they may leave out a bunch of things that happened just because they don't remember it happening. And so the witness will tell you, oh, okay, that all these other things that clearly show that this was a concussion. Just like we were mentioning, asking about migraine-like symptoms and observing particularly for inappropriate behavior can be especially useful. They may be excessively irritable or have emotional ability, which again, if you have a witness there to tell you this is not their personality, that is also very helpful and can kind of tip the scales towards concussion. And the last thing to remember is the symptoms may not be abnormal, may not present until minutes to hours after the impact. It is an evolving injury, especially within the first couple days. So just because they don't feel anything now doesn't mean they're not going to show that they have a concussion a few hours from now. So going into the vestibular-ocular motor screen, this is a screening tool, like it mentions. It's one portion of the cranial nerve exam. So you should still do a full cranial nerve exam to look for red flags, but this does not incorporate red flags. This is more specific for concussion. It takes about 2 to 3 minutes to administer, so you can get it done pretty quickly. And no one abnormality confirms concussion for this, but multiple abnormalities in conjunction with the appropriate symptoms and mechanism are highly suggestive of concussion. So if the history makes sense and you have one of these findings, you should treat it as a concussion for sure. The other thing is, again, may not be abnormal for several minutes to hours after the impact. So a normal exam here does not rule out a concussion. That's important to note. So again, it comes back to the history. So there's 7 components to the vestibular-ocular motor screen, and we'll go over them one by one. If you're doing this formally, the way that it's mentioned to be done by Mucha and co, who came up with this screening exam, you're going to do a symptom scale for each one, 0 to 10, based on each individual symptom, headache, dizziness, nausea, or fogginess. And that's useful if you are following them in clinic and you can kind of tell over time if there's improvement and how much. But if you're examining them just in the ED, you're not going to worry so much about this scale, just whether or not they have these symptoms while you're doing them. So first off is smooth pursuit. So smooth pursuit is something that you're always going to test for on anyone, and it's that smooth eye movement left to right. So you're testing for the basic cranial nerves while you're doing this as well. And so you're a few feet away, and you ask them to follow a finger, and you look for smooth eye movement. You do 2 seconds in each direction, and you want to make sure you're not going too fast so that you don't activate saccades, which we'll discuss shortly. And they just keep their head immobile and focus their eyes on the finger. So this is what normal smooth pursuit should look like. Notice it's exactly what it sounds like, which is nice and smooth eye movements back and forth. You're not seeing any stoppages or jerking movements in there. So this is abnormal smooth pursuit. And you can pretty clearly see the difference where it looks like it gets stuck going across, and it's a little bit jerky. So next up is saccades. So when you're testing for this, you're going to stand about 3 feet away and put fingers up about 1.5 feet away from midline. And what they do is they keep their head immobile and they just look at each finger back and forth quickly. You want them to do 10 repetitions each direction, and you're going to test horizontal and vertical. And so this is an example of normal saccades. As you can see, it's very quick. It's almost quick enough that you cannot even detect the movement itself of the eye. And also note that these eyes look very comfortable when they're looking back and forth, as they should normally. So briefly, I'm not going to go over this whole slide. This is basically the pathways of saccades. And I want to show this because saccades is one of the fastest movements your body makes and requires coordination of several areas of the brain simultaneously. And so it should come as no surprise that this is a commonly seen dysfunction in concussion, knowing what's happening on a cellular level. Now, abnormal findings in saccades, if they become symptomatic. So this applies for almost every part of the vestibulo-ocular motor screen. If it causes them headache, dizziness, nausea, or fogginess while they're doing these very basic eye movements, that is pretty consistent. The other big one is that it's going to be slowed. So they're not going to comfortably be able to look back and forth. It's almost like they're hesitating to do it when in actuality they're just having trouble moving the eye across as quickly as they normally should. Another factor is squinting. So if it looks like they're in pain while they're doing it, that is pretty consistent with concussion. This should not be uncomfortable when you're at baseline. Some other things you'll see is overshooting, where they'll actually look past the finger and then come back to it. That's fairly abnormal. And then undershooting and circuitous saccades, those can be baseline, so I wouldn't worry too much about those. That's where you don't look all the way to the finger and then you have to correct, or if the eye actually comes kind of in a circle or in an arc towards the target. Now, convergence is something that you normally test in a cranial nerve exam, but it's particularly useful here because we know that over 6 centimeters is abnormal. So you're going to do 3 attempts. The best attempt counts, and you have them focus on a small point, and you can do subjective and objective values. So that is when they say they start to see double or blurry, and when the actual eye, one of the eyes actually breaks off and disrupts the convergence. So you can also measure those points from when they say them. Mild discomfort is normal, but pain or inability to tolerate is not. So when I say inability to tolerate, if they're starting to do it and then they pull their head away because it's so bothersome, that is that's abnormal, and you don't even have to do the distance at that point. It's automatically abnormal. So this is an example of a normal convergence.
Now what you see here is actually the testing with the pin, just so that you can focus in on it. And it's going to go to the bridge, top of the bridge of his nose. Go. See how the eyes converge together like that. Let's do it one more time. Now what
Okay.
you see here is
So
actually with the pin, just so that you focus in on it.
he does a really good job. He gets all the way to the nose. So this would be a 0. And if you also notice, he kind of shakes his head a little bit after it's done, and that's normal. This does give you a little bit of annoyance when you do it, and that is not abnormal. So this is an abnormal convergence. So what you're going to do is is while you're looking at this, don't try not to focus on one eye by itself. Try to focus on the whole face, and then you'll be able to catch more easily which eye it is that's dropping out.
You got it? See the A? Yeah, okay. I need you to try to keep it though. Keep it 1A, okay? Keep your chin up a little bit. Keep it 1.
You see that left eye? That left eye dropped out. So you want to mark from that point, wherever your pencil is or your marker, you measure that to the nose, and then that tells you the distance.
Okay.
And again, over 6 is abnormal. So vestibulo-ocular reflex. It's not technically a true vestibulo-ocular reflex because you need to be unconscious to get that, but it mimics it. So basically you hold a focal point, maybe a stick with a point on it, and you just have them turn their head side to side while they look at that point. And if you're going to be very technical about it, they rotate their head 20 degrees in each direction, 10 repetitions each direction at 180 beats per minute, and you're going to do it horizontally and vertically. And for practical purposes, you're going to notice they're going to say it bothers them within a few head turns, and you don't have to worry about the actual beats per minute. They'll tell you if it's abnormal, and that's all you're looking for here. There's no actual physical findings. It's just whether or not they have symptoms. And similar for visual motion sensitivity. This point is you're just kind of making sure they don't fall over, because sometimes they do fall over doing this, and they're going to have their arm extended. They're going to focus on their thumb and then turn their whole torso, head, and arm to kind of in sync together, 80 degrees each direction, 5 repetitions each. And then this one is not part of the classic vestibulo-ocular motor screen, but I like it because I have seen it be abnormal several times, and it's anti-saccades. So anti-saccades actually tests your dorsolateral frontal cortex. And what you do is you ball your fists up about 1.5 feet apart from midline each side, and then they're going to look at your nose to start, and you tell them, I'm going to put a finger up on one side, and I want you to look at the other hand. So you're basically forcing them to overcome their reflexive saccades. Their brain's going to want to look at the finger that's raised, not the immobile hand. And so the first 1 or 2 times you do it, they're probably going to get it wrong, but they should be able to correct and do it correctly moving forward. So if they're getting like 1 right, 1 wrong, 1 right, 1 wrong, that's abnormal. So because their brain cannot overcome that. Now, next I want to go into balance. And when we're talking about balance, we're testing several areas of the nervous system, both central and peripheral. But the point I like to make here is that you're testing their function through the vestibulospinal tract. And now the vestibulospinal tract receives information directly or indirectly from the inner ear, cerebellum, vestibular nuclei, and the cortex. And it relays commands downstream to motor nuclei and ultimately muscles that maintain posture and balance of the head and body. So you're testing all of the components that contribute to that pathway. And in concussion, this is a subtle dysfunction because there may not be gross dysfunction of the individual components that provide better localization, such as ataxia or true vertigo. So I want to briefly mention the BESS because if you've ever sent someone to a concussion clinic or had sideline testing, this is something that's commonly used. For practical purposes in the ED, this probably won't be that useful because you may not have the foam pad necessary to properly score this. And the other factor here is typically you want a baseline as well, because depending on the person, like an athlete will be able to do a single stance or a front to back stance like this without a problem, but an older patient, a patient that doesn't exercise, may not be able to do this normally. So you kind of want to know what their baseline is. So what I prefer is actually a Romberg test and the Fukuda stepping test. The Fukuda stepping test involves the patient putting their arms outstretched and marching in place with their eyes closed. And then technically you're supposed to do 100 steps, but you'll see it quicker than that. Usually 20 steps or so, it'll start to present itself. And it involves an over 30-degree turn. That's abnormal. And the direction of the turn corresponds with the side of the lesion. So whether it's like one inner ear or the other. And forward movement is normal. So here is a example of that. So that should not be happening in your normal patient. As you can see, it's pretty stark. And then the Romberg test, very classic, feet together, start with the eyes open, then do the eyes closed. And prolonged swing, opening the eyes, or stepping out of position is abnormal. Now, the one thing I'll mention about this is that it's a little more useful in younger patients, because if you have elderly patients, they may have started to have a neuropathy in their feet. And so you can have an abnormal Romberg just from peripheral neuropathy. So if they have the peripheral neuropathy, you have to take this with a grain of salt, and it may not be as useful. But if they don't have any nerve issues in their legs, then it's suggestive of vestibular or cerebellar dysfunction, particularly with the eyes closed, because with the eyes open, they can overcome the imbalance using their visual system. And then I briefly wanted to go over red flags as well. So this is when you consult a neurologist. This is when you get imaging, and basically the main thing to notice here is loss of function suggests more than a concussion. So this is what you're scared of. You're scared of the epidurals, the subdurals, the contusions and subarachnoids, the bleeds. And so if there's weakness, numbness, recurrent vomiting, and when I say recurrent vomiting, that is anything more than once. Once, like you can have vomiting concussion, but that in itself is fairly rare. So once is okay. If they're doing it twice, you got to check. Vision loss or diplopia. Blurry vision is normal, and that goes back to the possible subtle convergence insufficiency that's occurring. But if they're starkly seeing double, or there's an area they cannot see, absolutely you need to check further. Altered consciousness. So in about 10% of concussions, there is loss of consciousness, but typically it doesn't last that long. I'll say, like, if it's more than 2 minutes, absolutely you need to check for something else, because normally they will kind of regain consciousness within 30 seconds to a minute. Asymmetric pupils, I'm always hesitant to put this in just because there is a thing called physiologic anisocoria, where pupils are just kind of asymmetric at baseline. That's in up to 20% of the population. So if it's less than a millimeter difference and they're both equally reactive, I typically say that's normal. That's nothing to worry about. If it's more than that, if you're looking at the pupils and you can already see something's very off, obviously then you need to check further. Seizure. So seizure is an automatic red flag because it's so rare within concussion. But there is a thing called post-concussive seizure, which in itself is not epilepsy and not dangerous, but still you want a neurologist to make that call. Slurred speech and aphasia. Slurred speech is fairly rare. That should definitely ring a red flag. Thunderclap headache. So pretty much every concussion patient that comes in is going to have a headache. The difference here is, were they fine and then all of a sudden 10 out of 10 worst headache of their life came on. That's where you're worried about, did they have an aneurysm that ruptured, and you want to check for subarachnoid. Neglect should never happen in concussion. That suggests a right hemisphere dysfunction. Combative behavior, they can be irritable, but if you do see that, then you want to just get a CAT scan, make sure they don't have like a frontal contusion. And then raccoon eyes or runny nose, that's basal skull fracture. Definitely, obviously, you want to get a CAT scan for that and look further.
So I want to go through the management of seeing a patient that's had a concussion, whether it's emergently in the emergency room or in the clinic. The first 24 hours after having a head injury, we like to have brain rest. So that doesn't mean going in a a dark room, a quiet room for 24 hours, strict bed rest. But it also doesn't mean waking up every hour. Traditionally, people were told you need to be woken up every hour to make sure that they're not having a worsening bleed. That is most likely going to present in the first few hours after having a head injury. And it's very important to get good sleep and rest after having a head injury so that way your brain can start to recover. We do like to avoid aspirin and NSAIDs for the first 24 hours if there is a bleed, so that it wouldn't worsen in that first period of time. That's where we say you can use Tylenol for the first 24 hours if you're having a headache. After that, it's going to be a gradual return to normal activities, both cognitive and physical. So this is going to be geared towards adults. In the pediatric realm, there are going to be state-specific and even regional laws that kind of govern how students are returning back to school activities. We always want to return cognitively first before we resume into physical activities afterwards. And here's where the individualized symptom management is going to play into a role here. So based on our history, our exam, we're going to tailor our treatment to each patient individually. So when do we want to see these patients? The sooner the better. As soon as we can evaluate these patients, get a good history, we can figure out which treatments are going to be the best for them. The sooner that we address these symptoms, the easier and quicker it's going to be to help resolve these symptoms. We want to address them sooner. That way they don't start to snowball and become harder and harder to treat as they go forward. It is a multidisciplinary approach, so there's going to be multiple people involved with the more complex cases. So whether it's neurology, physical therapy, psychology, and we also have to take into account their personal lives. So whether it's going to be schools, their work accommodations, family situations, we have to approach this from all different angles to see how it's going to affect the patient's life and how we're going to be able to address that and treat that going forward. So starting off with the most common symptom after having a concussion, it's going to be headache. We have two basic categories of abortives and prophylactics for a headache. In the common abortive medications, we have NSAIDs, anything from naproxen 500 milligrams to ibuprofen 800 milligrams. A Medrol pack can be very useful if they're having post-traumatic headaches that have been present for a couple of days. A Medrol pack can kind of abruptly stop that inflammatory pathway. Prophylaxis for headaches, we usually don't start that immediately after having concussion. We kind of reserve that to the persistent concussion symptoms, usually greater than 10 days, around 2 weeks. And that again is going to be based off of their symptoms and their side effect profiles. So tricyclics are commonly used because they help with sleep. Valproic acid can be very helpful in the ER to break status migrainosus. If they are having long-term headaches with other side effects, we can consider Botox or CGRP inhibitors, which are newer to the market now. We always want to screen for secondary headaches because that's something that we don't want to miss. So do they have a chronic subdural that just got worse? Do they have other symptoms that are suggestive of a tumor or mass or any space-occupying lesion that could be causing their headache? Next up, cervical. So this is another important thing that we want to screen for and examine because this can be triggering a lot of their symptoms from headache to vestibular symptoms. So we want to examine the myofascial system, see if there's any specific muscles that are tender that can be addressed. Again, we're going to treat them as we do any kind of myofascial injury with NSAIDs, RICE, so resting, icing, compression, elevation. If there's any trigger points, can we address that with trigger point injections with either injections or, again, conservative management with heating and icing. We want to screen for radicular versus plexus injuries. These are also common injuries that present with head trauma, so that will affect either the cervical roots or the brachial plexus. If we see any of those symptoms and exam findings, then we need to consider, do we need to get further imaging or do we need to get further testing with an EMG or nerve conduction studies? Addressing this also with physical therapy can be very helpful because that could help with a lot of these symptoms that will then trigger some other symptoms. Next up, we have vestibular. So as I mentioned earlier, BPPV is very common after having a head injury. We're going to diagnose that with Dex-Hallpike and treat it with the Apley's maneuver. There are a lot of videos online on how patients can do that on their own, but that's something that we want to do screen in the ER or even in the clinic. That can be very helpful for them. Treatment with that most commonly is meclizine, but can also be helpful with some short-acting benzodiazepines, can also be very helpful with those symptoms. Tinnitus is another common symptom after having a head injury. With that, we want to know, is there any different from their baseline, and when to refer out to audiology or ENT for other symptoms that could be addressed and treated. Physical therapy for more complex cases of BPPV, where patients can't do the Apley maneuver on their own. Physical therapy can be great for specific vestibular therapy, where exercises can be given in a monitored setting for patients to do with the therapist and then at home on their own. Next up is ocular symptoms. So as we looked earlier, the convergence is one of the most common ocular symptoms after having a head injury. So pencil push-ups are basically doing that exercise where we're checking for convergence, but we're doing that on a repeated basis to help strengthen the convergence pathways. So we would take a pencil or an object like your thumb, hold it out at arm's length, and slowly bring it in as close as you can to your nose, and basically trying to keep your eyes in focus. We would do that up to 10 times in a row, several times a day, and basically want to strengthen those pathways. As we do that, the convergence pathways get stronger, and that can help a lot with double vision symptoms and even symptoms of vestibular symptoms and off-balanceness. If those symptoms are also too difficult to be managed on their own, we can refer them to vision therapy, a type of occupational therapy or physical therapy, depending on your location. And neuro-ophthalmology can also be very helpful when symptoms get too difficult, whether we need to get prism glasses or further advanced imaging through an ophthalmologist themselves. Next up, we have cognitive and mood. So here we need to think about how their symptoms are affecting them in their personal life and in their work life. So depending on if they're middle school or high school, again, that's going to be state specific based off of local laws. But we want to figure out how we can help them in their school and in their work in terms of their cognitive activities. Do we need to limit some of their homework or work activities, reduce their usage of screens and electronics that can be triggering some of their symptoms, or even reducing the amount of loud noises that they're in, meetings or auditorium lectures, things like that. When cognitive symptoms can become too much, then we think about a neuropsychology evaluation, which can help figure out which domains are present and which ones are symptomatic. Mood, another thing that we want to screen for, comorbid psychiatric conditions. This is another thing that we need to address because that can snowball some of the concussion symptoms as well. Next up, fatigue. So it's very common after having a concussion to experience fatigue. Some of the easiest treatments for it are exercise and sleep. If you think about an athlete that's been used to exercising an hour to 3 hours every day and they suddenly stop, that itself is going to cause fatigue itself. Sleep commonly interrupted after having a head injury. That's another thing that we want to address, make sure patients have the proper sleep hygiene. And then we're going to gradually return them back to normal exercise, and that will help with fatigue. Another thing that we like to address with athletes specifically is physical therapy for a graduated protocol to help them return back to their normal exercise tolerance. So management, again, is going to start at the beginning. We want to manage expectations after having a head injury. Patients are going to do a lot of asking Dr. Google and seeing self-diagnosing themselves with CTE after having one injury. So we want to manage those expectations early on, sooner than later. If they're athletes, we want to do that in the beginning of the season so that they're able to recognize the symptoms so that we can address them sooner, again, before they snowball. Resources for patients, teachers, families, physicians. There's a lot of resources online. There's a lot of good ones and a lot of bad ones. A lot of the common ones that we use are the AAN has a website for sports concussion resources, and the CDC itself also has a lot of information for patients and family members. So I'll include those links in the chat box for everyone to kind of reference. Those are very good to give to patients and family members to help get more information from themselves. And then lastly, I just wanted to briefly talk about the field of sports neurology and how that's different from regular neurology and what it is we exactly do. So we're fellowship trained. After 4 years of neurology, we do another year to 2 years in sports neurology, where we address sports-related neurological injuries. So concussion is the biggest one that we address, but then we also look at peripheral nerve injuries, plexus injuries, muscle injuries, and spine injuries, how they all relate to athletes in particular, whether they're high school athletes, collegiate athletes, professional athletes, or even weekend warriors. All these kind of injuries as it relates to neurology, very important to address specifically in a different manner to help these athletes get back into playing sports. We also address neurological conditions and how they relate to athletes playing sports. So whether they have a previous history of migraine, seizures, stroke in young athletes, and MS, how we want to address that so that they can safely play these sports and what conditions we need to look out for and modify for. A newer aspect is performance medicine. So working on vision, balance, reaction time, sleep, and focus. So addressing these issues in normal, healthy patients so that they can perform better. So athletes now spend millions of dollars in this, trying to basically improve their normal physiology so that they can perform better. And so we address these issues so that we can help these athletes perform better. Thank you so much. If anyone has any other questions, we can start to address those in the chat box in the question and answer section.
Yes, so thank you, Dr. Patel, Dr. Corti. We very much appreciate all of that. We have some questions that have been posed both prior to now as well as in our chat here now. So I will address the most recent question was, how long for graduated return to normal? If they continue having symptoms for weeks to months after, for example, workers' comp, disability, lawsuit, so possible malingering. Can you help to answer that for us?
Yeah, do you want to take that one for management?
Yeah, so it's going to depend on their level to begin with. So if they're a high school athlete, we're going to aim for that 7 days, 7 to 10 days, getting them back in there. As we get a little bit older, it does get a little bit difficult on determining their, are they able to return to work or not. Most of the time, we can make workplace accommodations for them, so reducing them to light activities. But we also want to address what specific activities at work they would be are having difficulty with and what they're at risk for making their symptoms worse. So the history is very important in that, where we need to specifically tailor our treatment towards them.
Yeah, well, one thing I'll add on that respect is a lot of times it gets sticky getting like high school athletes back into their sports because the way it's set up is athletic trainers will need them to be like symptom free, but they may not have been symptom free before the concussion. So what we'll do is we'll try and get them back to their functional baseline and ensure that their neurologic exam is normal and there's no other signs that they're still concussed in order to clear them, because we want to get them back to play, because ultimately if they're still if you keep them out indefinitely when there's no other signs of concussion, that they just maybe they just have headaches, then they're gonna that's going to affect them on an emotional level, where maybe they start to not sleep as well because they're not exercising as much, and then they're not sleeping well. Their mood's off. They're not performing in school as well, and it becomes its own separate issue that has nothing to do with concussion. You actually make the patient worse by not letting them play. So it is a delicate balance.
Great. The next question is, what are your feelings on using software such as Impact for management?
Personally, so Impact was very useful in the when you don't have a concussion specialist available. So it's good because like it gives like statistics and numbers that you can kind of use to interpret whether something may be off, and especially if you have a baseline. But sometimes it gets used incorrectly as a way to decide when to send someone back to play, and that's not what it's approved for. So if you're using it as an initial way to screen for concussion, that's fine, but you should not be using it to keep people out of play. That is when you should be referencing to a neurologist or another concussion specialist on when they can return to play, and because the impact may never match up to their previous baseline, but again, it doesn't mean they're still concussed.
Athletes also know when to sandbag on those baselining tests as well. So
Absolutely.
we always have to be careful of our athletes purposely trying to do worse on the baseline testing so that they could eventually score better after having a concussion so that they can return to play sooner. Also, there is a learning effect with some of these tests where they will do better as we repeat the test. So that's also another thing where they might just do better on subsequent testing because they've experienced that exam before. So we all have to take that into consideration when administering this test, understanding where their baseline is and what they're at symptomatically after having an injury.
Okay. Are you okay with patients working through mild symptoms and progressing activity?
So I would say that as long as their symptoms are not aggravated by any of the work activities that they're doing, that's okay. We don't want any activity to worsen their symptoms. But as long as they're able to do work activities that are not aggravating their symptoms, that would be beneficial because we want to return them back into their normal routines as soon as possible so that we don't cause more problems by taking them out of work. And again, with deconditioning being another important aspect of it with their daily lives, we want to try and get them back into work as soon as possible in their normal routine. So as long as any of those work activities are not aggravating any of their symptoms, that'd be okay.
Yeah, the other thing I'll add is we don't want our patients to be scared of symptoms. So a lot of people think that like if they're aggravating their symptoms, they're damaging their brain more, and that's well, from what we know, that's not the case. So we exercise itself cannot damage the brain. Another hit to the head is what will damage the brain further. So we want them to kind of like know their own body. If you feel like it's making you worse, stop. But it's a graduated increase of exercise. So over several days, they should be able to do more and more. If they're not, then we need to figure out what something else may be going on.
Okay, great. What tool do you use to follow patients' cognitive complaints?
So with that, it depends. There's no one best thing. When you're dealing primarily with athletes, normally you use a SCAT-5, which has a great breakdown of memory, concentration, orientation. And on the sideline, we'll use part of the SCAT-5 is the Maddox questions, which screen for orientation within the game itself, and that's more useful than looking at than asking about just random year or month or president. With older patients, the MoCA or the mini mental status exam is also useful because then you can also later kind of use that to help with dementia screening or or other similar cognitive impairments. Just be consistent is what I'd say if you're going to use something.
Okay, and just I think we have time for one last question that came in, and they're looking for updates and new post-concussive rehab techniques, if you have.
Yeah, that's all going to be very helpful going forward, especially with patients that are having persistent concussion symptoms or post-concussion syndrome. It will be limited by the therapists that are available. Some are going to be specifically trained in vestibular therapy or specifically sports therapy. Going forward, that's something that you want to work with the therapist or the athletic trainer at their school to help find a plan so that they can return back to their normal activities as soon as they can, and help modify their activities as well to help with their symptoms.
Okay. I do want to acknowledge we're just a minute over on our time, so I did want to just thank everyone for joining us today. We appreciate your participation, and we look forward to sharing more with you in our continued Lunch and Learn series, so you can be on the lookout for that. We will be sending a follow-up with the recording of today's presentation, as well as the opportunity for you to also connect back with us if you had additional questions for our experts here, and they can reach out to you directly and have that conversation. So if you have any other questions, just feel free to contact us. And once again, thank you everyone for joining, and we hope you enjoyed the series.